to start the presentation on minimizing the advancement of heart diseases with dyslipidemia and coronary artery disease management. Well, uh, the managing cardiovascular disease in India is a challenge because it is one of the leading causes in India, causing almost 30% of the total mortality. And more than 50% of cardiovascular disease mortality is occurring in younger individuals of age less than 50 years. And this is something really, really worrying. Just to point out here that we are having this mortality almost 10 years earlier in comparison to our Caucasian and counterparts. The risk of cardiovascular diseases is higher in Indians because of probably higher LDL levels, which is more atherogenic, and more than 40% increase in MI is occurring even without established coronary artery disease, and 10% of myocardial infarction ischemia is occurring in age group of less than 40 years. So this data is really worrying for we Indians. So we need to be a little more sensitive towards management of cardiovascular disease. There are so many risk factors to cardiovascular disorders, of which dyslipidemia is probably the strongest, because this dyslipidemia with high LDL, high triglycerides, and low HDL is probably one of the most important contribution in causing acute myocardial infarction in we Indians. Of course, there are other causes like smoking, tobacco abuse, less intake of fruits and vegetables, our sedentary lifestyle, uncontrolled diabetes and hypertension, the abdominal obesity, as well as the psychological factors. Of these all, dyslipidemia is probably one important cause. To begin with, we have a case with a young individual of 47-year-old who is a male insurance agent, non-diabetic but a smoker, with little bit higher BMI of 25, blood pressure 130/70, pulse rate 80, with strong family history of diabetes that is in both the parents, with little bit higher LDL of 139, little low HDL of 42, and little high triglycerides. So little things are bad everywhere. 6 months from before today's profile, the triglycerides were a little more higher. The patient has been advised lifestyle modification without any medication. We all understand that there is no option modification. Despite any therapeutic therapy, despite any pharmacological medicines, we must have lifestyle modification. We have understood over a period of time that if we are able to increase LDL, say almost 40 milligram %, we are able to reduce the cardiovascular events by more than 20% in various categories, which could be major coronary events, coronary revascularization, stroke, or mortality. In all these situations putting together, we have more than 20% reduction in major cardiovascular events. Also, the cumulative atherosclerotic cardiovascular disease decreases with reduction in LDL, and this benefit goes on increasing as the time passes. So with time, there is more and more reduction in ASCVD. So every month, 1 millimole reduction of LDL reduces the risk of ASCVD by more than 20%. Over 10 years, it enhances to almost 30%, and over 40 years of management, this risk reduces by more than 50%. And this benefit further increases if we are able to reduce the LDL by 2 millimole per liter, and this is almost doubled, almost 1.5 times to 2 times greater benefit. Coming to the guidelines, over last 20-25 years, we have various guidelines under the various bodies who have changed the LDL parameters where we should reach when we are trying to treat the LDL. We began with less than 130, and today we talk even less than 55 in very high risk group of patients. But on an average also, we look forward to an LDL of less than 100 when we talk of reduction in LDL and preventing the ASCVD. Even the European and American guidelines have suggested reduction in LDL is the primary target, which must involve both pharmacotherapy and lifestyle. Of more than 50% reduction of LDL from the baseline values has shown its benefit even in primary prevention, and various risk scoring systems, including the European and American systems, have been developed which has shown this benefit. Coming to the American ASCVD risk calculator, the 10-year risk factor of more than 6% has shown to be benefited. They have also found that we Indians and South Asians are not being assessed and are underestimated when it comes to the risk calculation. The 50% reduction in LDL has shown to reduce the ASCVD by more than 50%, as has been proven in various guidelines, even as primary prevention. This has been explained. The same thing has been explained here in a graphical manner when it comes to reduction in LDL and benefit in terms of reduction in ASCVD. The number needed to treat for this more than 50% reduction in LDL is 63 when it comes to 20% reduction in baseline, and it is as less as 26 when it comes to reduction of 50% of baseline reduction in LDL. So we see that as we go on increasing the reduction of baseline LDL, the number needed to treat reduces to prevent one event. So higher the reduction in LDL, better is the benefit. Also, this therefore the decision making for reduction of LDL and reducing cardiovascular events is important, and which has been proven in various studies. The ESC guidelines has also showed benefits of management of dyslipidemia in various situations where the LDL is low to high. Even when the CV risk is higher, we need to have lower LDL targets of almost 55, and when the risk factor is not that high, we can have little bit higher LDL of up to 120 mg%. Here, the European guidelines have classified in various categories the patients in primary and secondary prevention, as well as according to the risk factor from low risk to very high risk, and what should be the LDL levels. As we have seen in earlier slides, it is further explained that depending on the risk factor and depending on the primary or secondary prevention, anywhere between 55 to 200 mg% of LDL should be targeted. Otherwise, we are heading towards ASCVD. We must reiterate here that lifestyle modification is important at all stages along with pharmacotherapy when we talk of treating the LDLs. We have class 1A recommendation for using high intensity statins if they are tolerated when we are talking of reduction in LDL. Coming to the primary prevention, we have various molecules like Rosuva, Atorva, Fluva, Lova, Pitava, Prava, and Simvastatin in management of dyslipidemia. They all have their own benefits. Some are hydrophilic, some are lipophilic, but those molecules which are hydrophilic and are not metabolized by CYP450 and have dual clearance will definitely have better tolerance and lesser side effects, and that holds true for rosuvastatin. Rosuvastatin has been shown to reduce the LDL by 50% within 1 year of treatment of dyslipidemia, as has been proven in Jupiter trial, which also helps in reducing the triglycerides and C-reactive proteins. It also helps to increase little bit HDL. But when we talk of HDL improvement, we must remember the most important thing is regular exercise and taking care of the diet when we talk of benefit in terms of HDL. There is no second thoughts about it that HDL improves best with exercise. The Jupiter trial also has shown reduction in mitral infarction, stroke, unstable angina, revascularization, cardiovascular death by more than 40%, and mortality reduces by 20% when we are able to use rosuvastatin for management of dyslipidemia. The benefit of rosuvastatin has been proven in all class of cardiovascular diseases in various numbers, which is not less than 40% at any point of time. So here one point also comes into mind: do all the brands are same? Because the innovator and the generic brands have some differences. They may be having differentiation in bioavailability, and probably that is the thing. The absence and presence of impurity makes probably the difference. The innovator molecule is obviously better in comparison to the generic brands. Price may be a concern, but the tolerability will be much better with the innovator molecule, probably because of its purity. That holds true for anything in the world. The more pure, the better it will be. The presence of methylated impurity in generics is probably the cause for this lesser tolerance, more intolerance, and lesser benefit in terms of management of dyslipidemia. This is probably somehow seen more in atorvastatin, probably because of the non-inhibitory effect of HMG coenzyme, and therefore we have the global efforts towards managing dyslipidemia with the probably better results with innovator brands. The benefits of using innovator has also seen in terms of greater benefit in terms of CV events, because there is almost 30% lesser CV event when we are using innovator brand in comparison to the generics. Here we see the chemical composition and the differences and the presence of impurity, which makes the difference in innovator and generic brand. The sympathetic overdrive is another important cause for coronary artery disease, and this is present in more than 90% of the patients. One of the important reason for this being this, that we are having sedentary lifestyle and we are stressed, for which we generally do not talk to our clinicians. Also, we are not spending, as a patient, we are not spending sufficient time in our social activities, may it be friends, may it be hobbies, and invariably our culprit is work, which may or may not be actually, but we blame that. I guess it is the mindset which is more important, and sometimes the financial constraints are also there, which is an hindrance in managing such situations. We may require professional, experienced things, and somehow this COVID thing, which happened in the last couple of years, has also tend to increase the stress and anxiety. And there is a little financial constraint, which has led to little more problems, which we are seeing in recent times. More than 60% of Indians are hypertension, having sympathetic overactivity, and one of the important causes include tobacco abuse, maybe smoking, maybe snuffing of tobacco, maybe chewing tobacco, along with obesity, sedentary lifestyle, stress, and diabetes. So we must need to take care of that. There are multiple homeostatic mechanisms which lead to sympathetic overdrive. Therefore, energy balance, the control of blood pressure, is important when it comes to the chronic sympathetic activation, because this will lead to metabolic syndrome as well as other cardiovascular risk factors. The reflex mechanism, the baroreceptor impairment, the metabolic factors, the humoral factors also come into play, and that can trigger the situations further ahead. So what we can do about it? First of all, we should try and understand what is happening due to sympathetic overdrive. There is net result of increase in heart rate and therefore activation of various CV risk factors. Due to sympathetic overactivity, there is arterial constriction and therefore reduced blood flow to the muscles. Also, this will further enhance the insulin resistance as well as obesity, and the increase in oxygen consumption may lead to ventricular arrhythmias. All these put together, along with lipid abnormalities and inflammation, can lead to the coronary event, and therefore the sudden cardiac death. Another situation could be increase in hematocrit values, the plasma volume reduces, there is venoconstriction, the cardiac output is enhanced, and therefore hypertension. So another risk factor for CV event. The increase in heart rate causes increased arterial stress wall, the LV apoptosis occurs, the collagen fibrosis increases, therefore there is LV stiffness and there is LV dysfunction, there is plaque formation, there is endothelial dysfunction, and ultimately it can lead to heart failure and increased mortality. Smoking, due to the nicotine and the presence of sympathetic ganglia, causes release of norepinephrine, which causes vasoconstriction, which increases the peripheral resistance and therefore increase in both heart rate and pulse pressure. Smoking is one of the important causes to increase the norepinephrine, which is increased almost 2 to 3 times in presence of nicotine. And therefore, the increase in cardiac mortality is there. And for every one increase in symptoms, there will be more and more increase in disorders. The patient may present with tremors, patient may speak fast, there may be restlessness, there may be perspiration, and when it is occurring in younger individuals, the risk is further increased almost twice in comparison to older individuals. The elevated heart rate is definitely a risk factor for cardiovascular mortality. The increase in heart rate increases the adverse events in coronary artery diseases. Therefore, a heart rate of 70 should be generally maintained because that will be acceptable and not causing increase in CV mortality and morbidity. This will also help to reduce the hospitalization for heart failure and hospitalization for myocardial infarction. And this increase is almost 30 to 50% when the heart rate is higher. The increase in heart rate not only reduces the morbidity, but also the mortality by almost 10 to 15%. The beta blocker is first-line treatment according to the European guidelines or American guidelines, which helps to reduce the angina, post-MI situations, heart failure, and controlling heart rate because it will reduce the myocardial oxygen demand, along with other molecules like ACE inhibitors or ARBs, along with the statins and aspirins. We may need to use nitrates in post-MI situations. The coronary artery disease should be treated with beta blocker because it takes care of sympathetic stimulation by reducing the heart rate, improving the cardiac contractility, and reducing the myocardial oxygen demand. Metoprolol is beneficial, we all know. It averagely reduces the heart rate by almost 15 beats per minute, and it is unique in terms of half-life of almost 3 to 4 hours with excretion hepatic, and there's no accumulation of drug even in late stage of renal disorders. So this is some of the special benefits with metoprolol. All-cause mortality and sudden cardiac death reduces anywhere between 20 to 30% with uses of metoprolol. The ZOC is a technology which they are using in this particular brand, Silicon XL from Astra. Of course, this is a sponsored lecture, so I'm sorry for this brand thing. So this is a gel-based metric system which releases the drug over a period of 10 hours where 90% of drug is being released. This multiple unit pellet system is being used, which maintains the plasma concentration for 24 hours. The metoprolol succinate is in the pellet form, which are combined in a tablet, which is released over a period of time, and therefore we get a benefit over 24 hours. So this is the what I say, the pharmacokinetics and pharmacodynamics and structure of this particular molecule of this particular brand. The release is not affected by the food intake, the pH, or the agitation of the molecules. The benefit of using the OD brand is once a compliance. So compliance is better because of once a daily dose. Plasma concentration is maintained for 24 hours. High beta selectivity has lesser side effect, better tolerability, and not affected by other parameters. With these, I come to my last slide, that sympathetic overactivity is further enhanced in diabetes, obesity, smoking, and stress, which are anyway risk factors in Indians. Increase in heart rate causes increase in cardiovascular mortality. specifically in younger, where it is increased more than twice. There is a reduction in sympathetic overactivity by almost 15 beats per minute of heart rate reduces with metoprolol. Sudden cardiac death reduces by 30%. All-cause mortality by more than 20% in coronary disease. Uses of metoprolol and rosuvastatin along with other medications is definitely helpful in managing coronary disease, which is a definite concern in patients of Indian background. With this, I would like to thank you all for patient listening. Any questions?